Uh, all attendees, I will uh, speak briefly about the Professor Erik, who is now Professor Emeritus since April 2001. He has a lot of teaching activities locally and globally and over the world. I think last time I sharing Professor Erik in Dubai with our friend Dr. Sanjeev Nanditkar. He will the next talk. I think uh, next week. Professor Erik, one of the eminent in single fiber imaging, neurography, chair of the European chapter of IFCN. Also, he is an organizer and chairman of the muscular dystrophy research. A lot of activities. So we are so excited now to start early from the time at the Professor Erik Sweden. But let's go. Floor is yours, dear Prof. A lot of participants there at this webinar, about 300 registers. As well, I will share in the association as well. Yes.
Okay, thank you very much for the introduction. And dear colleagues in Egypt, it's a great honor for me to talk to you a little today. And I am now sharing my slides here, and I hope for the best that it will work. And here are some slides. And do you see this now as?
Yes.
Thank you. It says neurography, an introduction, because some of the things are new and maybe some of you are in your residency, so early in the education. And we also have an update because there are some new things that has happened over the last years. The usefulness, as you all know, is for the general nerve condition, polyneuropathy, and also for local neuropathy, local abnormalities. And I will talk about principles of this. The way we do that, you are all familiar with that. We stimulate the nerve and record from the muscle under study. The stimulus point is here at the cathode, and the recording is here at the end of the recording. So we measure between this one, usually the center of the electrode, usually the center, and usually the point of cathode. And here I will show you one very special thing. Namely, what you do in your routine is to record from the muscle and from a reference. We call that electrode 1, electrode 2. And the reference should not be at the tendon of the muscle. In all literature, we saw belly tendon. Now it should be at the very end of the finger, the last interphalangeal joint. Because we want to have this as silent as possible. I wanted to know if this was active and if this was active. So I recorded between this muscle and something that is completely zero. And then I also looked at if E2 is active or not. And here is our recording, the normal one between APB and the thumb. And here is the recording between APB and a remote. And here is the reference. And you see, this is pretty good. The thumb is relatively zero. And this minus this will create this one. But when we stimulate proximally, then we see some very special early downgoing. This is called positive wave. and also to the reference, we see the positive wave. And when we superimpose, you'll see they are identical. And the black minus the red will show 0. So that is wonderful. But what is this? Well, this is when we stimulate the median nerve at the elbow, then we stimulate forearm flexors also. So this is remote activity, distant activity from forearm flexors. And that is a disturbance heard to equal amount from one and from the other electrode. And that distant activity will be cancelled when we do our normal recording. That's why we always use 2 electrodes relatively close, but far enough so that one is 0. Here is the same trick for the ulnar, and we test here and here. And this is our daily recording. Often we have 2 peaks when we do the ulnar. This one is the recording from the ADM. This one is upside down, big recording from the little finger. Very funny. And when we get this, this means that we are recording from from small hand muscles, interosseous muscles. They are heard here as a disturbance. And when we take black minus red, we get this thing. So this is from the ADM. This is from the intrinsic muscles. And there is nothing we can do about this. We have to use this, and we have to record from the highest, if it is this one or this one. When we stimulate proximally, we get the same thing. We get this one and upside, exactly the same, because that is generated in the hand. This may be from some forearm muscle, but the principle is that in this muscle, we have the disturbance from inside the hand. Here is the same thing, but from the foot, from the tibial nerve, abductor hallucis. This is our routine study. But when we look at the reference minus remote, that means big toe minus remote, that is not silent. It has a big positive glowing signal. And the abductor hallucis instead is very, very small. And this minus this will give this signal. So the big signal that we record from the abductor hallucis minus the big toe, that is mostly not from the abductor hallucis. The main thing is coming from the foot muscles. And you have all the small foot muscles in the sole of the foot are tibial innervated. So this is a significant artifact, but we have to live with it. And since it is tibial nerve, it is still a greeting from the tibial nerve. When we stimulate the tibial nerve proximally, we usually get a lower amplitude because of problems with the temporal dispersion and so on. But we also get an early component here, exactly the same from the big toe as from the abductor hallucis, and they subtract and we get 0. And this is from the muscles in the leg that we activate when we stimulate the tibial nerve. The same thing with the tibialis anterior. The tendon is very active. Here is the tendon. You see it has big problems here. So we should use, the reference should be the patella. You see, patella is silent. So the real best recording is this one, patella, the tibial anterior to patella. So you should use the patella as the reference point, not down at the tendon. And the same thing for the biceps, for example. It should not be at the tendon, but it should be up to the acromion. Here is a new thinking that we just published a short time ago. Here is the recording when we do the nerve conduction study with the surface electrode here. And the surface electrode cannot hear very deep. We can hear about 2 centimeters of the muscle. So if we have a small muscle, like in children or in eye muscles or in small hand muscles, we see the whole muscle. But if we're recording from the biceps muscle or rectus femoris, we only hear a small portion of that muscle. And this is the reason that explains why the difference is not so big between small and large muscles in amplitude for different muscles. Because the area that we record is about the same. And also this one, if we have atrophy, then we see that the atrophic muscle becomes smaller. We get smaller signals. But if we have, if we have a large muscle that becomes smaller, it really doesn't matter so much because we still hear down 2 centimeters inside the muscle. So atrophy is seen much more in small muscles to start with than we see atrophy in large muscles. And also this is the reason why we do not have so big changes in amplitude between children and adult muscles, because in children muscles we see the whole muscle, and in adult we see only a part of that muscle. So this is new thinking and can explain if you have been thinking, why is there so little difference in the early age and the later age? And another new thing that we have discussed long ago, but that we have tested scientifically a little more recently. This is one of the slides I used long ago when I measured conduction velocity to the takeoff to 1 millivolt up to halfway up to the positive or the negative peak. If we measure to the peak or other part, you see 59, 57, 59 meters, 61 meters. It really doesn't matter where we measure. Earlier, and maybe you also think that the early part of the CMAP is the fast axons and later part is slower axons, but it doesn't seem to be so. And now we have tested this a lot. And you see here the distal and proximal response in median nerve. Here is one test. You see how similar they are. How similar. Look at this. Very, very similar. You can test this in your EMG machine every day. If we have full stimulation, the signals do not differ much. If the proximal had, if they had represented that this is the fast and this is the slow, then they should have been shown a different time dispersion if we have short or long distances, but we don't see this expected dispersion in time. So I think really that the fast and slow axons are seen spread out within the CMAP. And the schematic thinking is the following. Here is a nerve, here is a wrist, and here is a muscle. When we stimulate the nerve here, they arrive according to the conduction time. Fastest axons come first, and the slowest axon come little later. So this is the normal expected difference. But when we get inside the muscle, from the wrist to the muscle, then every axon is getting thinner and thinner, and they start to conduct not with 50 meter, but 20 meter or 10 meter, and it's very different. So some are much thinner than others. And in addition, the motor end plates are at different locations. They are not in just one narrow, nice zone, but they are spread out much more than we think. And therefore, the arrival time from the wrist to the end is not related to the arrival time here. So the total time will vary very much. This is the expected time. You know, if this one had been conducting here, this is the expected, but this is what we get. We get faster and slower and faster and slower, independent on the velocity. So changed order of arrival due to different degree of slowing in distal axons. Most of the dispersion takes place distally. And this is a new thinking, and it has to do with our interpretation. What happens if we have low amplitudes? Is it really loss of only fast, or is it loss of random size motor units, axons? Here I will show a few parameters that are important for our neurography recordings. The electrode type and position, muscle length and temperature, and so on. You know many of these things already, but I will just mention a few others. And then we have the real thing where we have dependence on number of axons, size of motor units, axonal diameter, and myelination. Let us look at the problems. If we have an electrode that is elongated and record from the entire area, it's a big recording area, then we get 9.9 milliamp in this millivolt in this electrode. Here we have another electrode that is little elongated, and if we have it across the muscle or along the muscle, we'll get different values. Here is across the muscle, and you see the same muscle, instead of 9.9, we get 12.3. And here is a rounded electrode, and it doesn't matter the direction of this, then we get something in between. So this is 25% difference, just depending on the shape of the electrode. So my advice is nothing is absolutely correct, but you must use one type in the laboratory, and you must have used the same electrode for reference values as you use for your patients. Here is another thing is that if we have make the muscle shorter. For example, here is from recording from the APB, and I mechanically make the muscle little shorter like this. Not activating, but just shortening the muscle. Here is the muscle in neutral position, shorter, 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 shorter. You see that the duration will decrease and the amplitude will increase. 7.1 millivolt, 8, 9.5, 10.6, 12.2. Can you see? It's a very large difference. It's 60-70% difference. And duration 6 down to 4.7. So it changes the shape a lot. And when we do sometimes people do a high frequency repetitive stimulation. Then during the high frequency repetitive stimulation, the muscle becomes shorter and shorter, and we cannot do the recording of the, for example, decrement during the ongoing train of high frequency. We do the high frequency, and then we must make a 2-3 seconds rest, elongated the muscle, and make the study after the stimulation train. This is an important technical feature. Another thing is that, as you know, the distance between stimulation and recording will give different shape of the response. Not so much for motor. Here you see motor, the distance is 8 centimeters, 12 centimeters, and another 8 centimeters. So it becomes smaller and smaller and little longer, and it changes a little in shape. Not so much. It changes here 15% in amplitude and other percent. On the sensory side, since the signals are shorter, they must be very synchronous to summate to a good signal. If they are a little desynchronized, they will decrease in amplitude very quickly, going down, down, down like this. So therefore, all our studies must be related to the distance between the stimulus and the recording, particularly for sensory signals. And this is the most important for the sensory side. Our routine is to have a standardized distance for all our recordings between stimulus and recording, which is the best. Sometimes it's difficult, small hands, large hands, but as long as we can do it, it's advisable. And the stimulus artifact problem, we all have that. I just want to say that there is one trick. Some machines provide a biphasic stimulator, and that is good to test and see if that can help a lot. Otherwise, another good advice is to rotate the stimulating electrode around the cathode, not the anode. The anode moves and the cathode is sitting on the same place on the nerve. Well, here are the measurement. Is the latency area is sometimes used, but we don't go into the difference there now. Most people use amplitude for different measurements of both motor and sensory amplitudes. Here is the well-known principle with distal stimulation, with a good response, proximal stimulation, the same response, nearly the same response. And if we have an axonal degeneration and we stimulate distally here, the amplitude will become smaller if the degeneration has been going on for more than a week. If we cut the nerve, there is no change after 1 or 2 days, but later the amplitude goes down. If we stimulate above the problem, we also get low amplitude. But for those axons that can pass here, we get the correct latencies, but the amplitude is low. So axonal degeneration, normal conduction, but low amplitude. And there are some rules for that you know. But often the conduction velocity is in median nerve more than 40 meters per second. That is a kind of tipping point. Here's an axonal neuropathy, conduction velocity 48 and amplitude 0.3. This is typical axonal. And here you see the low amplitude, both motor and sensory. For conduction block, for example, when you have been sitting with the legs crossed or we have an abnormality in Guillain-Barré, if we stimulate distally, we get good amplitude. If we stimulate proximally, we get lower amplitude. And we usually say that conduction block is when this is decreased by so and so many percent. I will show that later. Here you have a good amplitude of 3.7 millivolt, and if we stimulate more proximally, it is only 1.1, so it's a loss of 70% of the amplitude, and the F waves also have been reduced in number by 70%, the same decrease. And here is the figures we have been using. If the amplitude goes down in the arm nerves by 25%, fibular 30, tibial 55, and if at the same time not increase in duration, that we called conduction block. These are figures that we have used quite many years. Recently, I think that we're actually with very strict recording, stimulation, and so on. In future, this will go down to 10%. So try to get it smaller than 20%, but with very good recordings. So here is the criteria again, 25% decay and very little of dispersion, fibular nerve 30%, not so much dispersion, 55%, 45% dispersion. This number you see in the handouts that I have sent to you. Conduction block, that signals are really blocked. That means that no signal is reaching the muscle and therefore we have weakness. Temporal dispersion, that means the signals come a little later, but they still arrive. If they just come a little later, there is no weakness. So temporal dispersion does not give weakness. It gives low motor amplitudes, but no weakness. Then we have the next condition, and that is demyelination. It can be along the entire nerve, or it can be just locally. When we stimulate distally, it's not so much dispersion at all, so good amplitude. But if we stimulate proximally and proximal to the problem area, then we get slower velocity. Therefore, the latency is increased, and also they are broader. It's a temporal dispersion. Like here, you see the amplitude is good. It's only 16% drop in amplitude, but the velocity is 35 meters per second. And here we also have rules that if we have velocity below 38 meters per second in median nerve, then we likely have a moment of demyelination. And the problem with what I have said now is that we do not have an absolute clear distinction between axonal and demyelination, because the axon depends on the myelin depends on the axon. So often they go together, more or less, and we have to judge, is this mainly an axonal or is it mainly an demyelination? I think it is important for us clinically to find the demyelinating disorders with conduction block, because conduction block often is due to an autoimmune disorder that is potentially treatable. So that is what we want to show. Yes, what do you want to say? I think we had a question, or maybe, okay, I go on. I don't hear anything. You must activate your microphone if I should hear you.
And if anyone need to ask Professor Erik,
Yeah.
someone raise his hand. I think
Okay.
two. Okay, you can continue, dear Prof. Yeah.
Okay. Then we go on a few minutes with the late responses, which is something important for. Here we have somebody that raised the hand. Can you speak, please? Okay. Late responses study, I think, is an important part of the neurography in routine, particularly the F responses. But then we have many other late responses also. Some are clinically important, some are not so important. But the F waves is, as you know, the following. You stimulate the nerve and get a muscle response, and the signal goes in the antidromic direction, activates the motor neuron, and the motor neuron can now reactivate the nerve when it's still charged like a battery and can activate again. This does not happen every time for every stimulus, but only in 5% of the stimulus. So sometimes it's one neuron, sometimes it is another neuron. As you see here, sometimes this neuron, sometimes this, sometimes two or three, sometimes two, sometimes four. So here is the CMAP, the motor response, and 20 microseconds later, we have these F responses. And we measure the shortest latency here usually. That is the principle. And some technique, we also use the latest F response and measure between them, and that is called chronodispersion to show the variation in slow and quick. So, but the shortest is our routine, and we often subtract. We take the F response time from start to F response minus this M time, the distal latency, and then we get the time from the wrist up and down to the wrist again, because we have subtracted the distal part. And this is the normal reference. It should be faster than this line, depending on the patient's height. But if we have a neuropathy, here's diabetic neuropathy, all of them come after this limit line. And that is useful, and I don't need to spend more time on that. You all know that very well, and the usefulness. But here is another thing. Sometimes we have too many F responses. You see, if we have many, it looks like they summate on each other and they fill up the signal. Your eye can see that we have more here than here. The same in the same patient from the ulnar nerve, much more here than here. This is a sign of spasticity. And this was a patient with a right-sided central lesion, very slight, and clinically we were uncertain about the reflex asymmetry, but here it is clear that it is an asymmetry. So we can report that and go back and check our patient clinically. It is an extra information that we get from the CMAP. Sometimes this is seen as repeater F wave, the same. And you see that better when you superimpose them. When we have repeater F waves, which is not common at all in normal muscle, then it is indication that some neurons are hyperexcitable, and it's not as much as spasticity, but they are hyperexcitable, and it's usually in neurogenic conditions that we can find this abnormality, repeating F waves. And here is another thing that you see nearly every day when you do your recording in a patient with neuropathy, namely when we stimulate, the signal goes to the muscle, but it also goes up not only to the motor neuron, but somewhere in the middle of the axon, a new impulse starts and come back, and we call that extra discharges or intermediate double discharges or A waves. Some of them perhaps is not due to this phenomenon, but the mechanism can also be a late signal conduction in terminal nerve trees. In CIDP, we have much more of this. We call it M satellites, that we have a problem distally. We can differentiate the two, but I don't go into that. Here is an A wave repeated with constant latency for every discharge. And here is also an A wave. Can you see? It's the same response all the way. Usually they come before the F, but sometimes they come after or inside the F. And you say, oh, how is it possible that you can get something after the F waves? Yes, if the A wave is due to an abnormal axon, it can easily conduct more slowly than normal, and therefore they occur later. The A waves, they are from the peripheral nerve. It's an ion channel problem. F wave comes from the motor neuron, and it is in indication of neuronal excitability. And the H reflex, then we study both the motor and sensory axon, and maybe we do not have time to go into that right now. Here's another thing that can be important for us when we have local changes in the nerve, in ulnar nerve, in the fibular nerve, and so on. That is when we do stimulation at many different points, usually 4 points below and 4 points above the sulcus ulnaris. And then we get this harmonic increase in latency. This is a normal situation. Same amplitudes, a little lower with increasing distance, but this is harmonic, nice. And sorry, I must show this slide also. Here, if we have an abnormality in the retroepicondylar region, then we have increasing latency when we stimulate below the sulcus, and then at the sulcus, all of a sudden, we have a jump, and then they continue like in the normal nerve. So it's a jump here, which is, this is a better way to look at the latency than to calculate velocity, because that varies too much. So this is a good way, and we compare this, and we see the difference between the two. Then we shall continue with the slides that I had that I wanted to show you. Here is again just a reminder that the difference between demyelination and axonal is sometimes difficult. Here's velocity, here's amplitude. If we have low amplitude and normal velocity, it's axonal. If we have low velocity and good amplitude, it's demyelination. But the problem is between, and then we say it's mainly so or so. Then a few words about sensory testing that is also a part of the neurography. We usually use for recording fixed bar electrode with 23 millimeters, or you can use also ring electrodes. But if you use ring electrodes, it's very important that you every time use exactly the same distance between the rings as you use for reference values. Here is the test I have made. If the nerve goes in this direction, what is this one recording? Yes, this one. And what is this one recording? Yes, this one. A little later, you see it's delayed. It takes some time, travel time across the electrode. And what we record in our amplifier is this minus this, and that is this one. So this is a part of, is a difference between the two recordings. And here I have tried to simulate if the distance is very small here and it's longer, longer, longer. And then when we have very small, we get small signals. And if the distance is longer and longer, it goes up to a maximum. And then when you're very long, you start to see the effect of the other electrode, and you get the more complex signals. This is to tell that we need to be very careful with the distance between rings if we use that, but we prefer and we recommend the fixed bar electrode. The measurements are takeoff here, that is the positive peak, the negative peak. Amplitude is usually between well, there are different techniques for that. And this is the duration between them, like this. When we do the sensor recording, it is important that we try to get rid of artifacts. And you do that in the averager in your EMG equipment. But another good thing is to start with removing the high frequency signals. Then it is easier job for the averager. So here is the signal, raw signal. And if we remove the disturbing signals, then you can get so much nicer signals by just using 3 kilohertz cutoff. So change your filters from 3 kilohertz to 10 kilohertz in your amplifier. Cut off everything below 3 kilohertz. So we have now been talking for 47 minutes, and we have time for a few questions. So thank you very much for listening. I think that these were some old things that you knew, but some things that may be a good thing to remember, that this technique, neurography, both motor and sensory, is very useful, and it gives more details than we can imagine. And if we had only EMG and neurography in the EMG lab to choose, and if we must choose the favorite, that is the neurography. It is quantitative, it is non-invasive, and we can get help from the technicians to do these studies. So thank you.
Thank you so much, dear Professor Stalberg, for this amazing, fruitful, and very informative talk, as usual. Let me start with my first question. What about in carpal tunnel syndrome, the residual latency?
Say that, what about?
Residual latency, NCTS.
Residual,
Yeah.
Residual latency is let me see if I did not have a slide. That is here. If we have a certain velocity here, 50 meters per second, then we expect that after 8 centimeters, the response should come here. And that is the expected time. But it comes much later, it comes over here. And the difference between the obtained velocity and the expected, mathematically expected, that is called the residual latency. And that has been used for some people instead of the other measures. So it is again an indicator of that the velocity is not the same here as here. The residual latency says it takes longer time than we expect.
Okay. I think we have, please, if you open the Q&A box, you will see with me the questions. Thank you for the valuable lecture, sir. So what is the difference between intraoperative neuromonitoring and the nerve conduction study in the field of the neurodiagnostic field? This is the first one.
I think in the intraoperative monitoring, it depends on the principal situation. If it is a local study, then we should do the stimulation below and above the area where they stimulate. And it can be very helpful. We can say that there is a continuity of the nerve. It is some conduction. And now with this operation, now you can see it much better conduction. We can make a lot of good things with just studying below and above a problem. and many other more things also. But this was one example.
Yeah. In inching technique, Professor Erik, Professor Kimura prefer to use the sensory inching in distal CTS, in distal median at the wrist, more than the motor inching. What do you
Very
think?
good questions. He has very nice pictures of that. We think it is time consuming. We think it's very nice detailed study, and it learned us that the main compression is at the distal end of the transcarpal ligament. That is what we learned. But nowadays, we use antidromic recording from the finger, stimulating here, get the normal time, and stimulate here and record here. And the difference between the long time minus this time will tell us this time, and that is prolonged in carpal tunnel, and that is a very,
The current
very,
mode.
that is a very good thing. So we do not do the inching.
Mhm. Other thing in inching, short segment at the elbow, ratio, the interim side at the elbow of the ulnar. The optimal distance is about 1 centimeter or 2 centimeters.
Thank you. If we have longer distance, for example, 10 centimeters, we cannot say exactly where the problem is lying. If it is in the flexor ligament here, or if it is under the elbow, or where it is. Therefore, we do not use 10 centimeters, 5 centimeters, little better. And if we use only a 1 centimeter, then it's little more problem to measure exactly the distance. So we start to come into problems, and therefore I showed you the technique of drawing a line between the signals than to trust only the velocities. So I say 1 centimeter is very good to because it is more sensitive to detect exactly where the problem is, but uh, it is also given some problems with velocity. Here you see it looks very nice, but maybe a little error here. You see velocity 49, 48, 40, 30, 60. You see it varies. So therefore, we think this line shows clearly that we have a delay here. And also, I superimpose to look at the amplitude drop, if it is an amplitude drop between this group and this group. So we get both latency change and amplitude change. Neurophysiology is very good, but here we had also good help from the ultrasound technique.
Yes, yes, sure. I'm sorry for take long time for asking, but what about the percent of degeneration in facial nerve pathology, Bell's palsy? Percent of degeneration
Percent of degeneration.
in
What
facial,
did you
in
once again?
facial nerve neuropathy.
Yes, in
Yes.
facial.
Yeah.
Okay. We have a very simple technique that
Yeah.
we record between the nasalis, and maybe we have the reference here, and compare to the amplitude on this side and have reference here. If the amplitude here on the paretic side is very low, if it is only 10% of this side, then we have an axonal degeneration, and that is a bad prognosis. It takes many months. If the amplitude here is nearly normal compared to this side, and the patient has a facial paralysis, you say, oh, this is funny. It makes no sense. The patient cannot move, and we still have a good response. Then it is only a conduction block in the inner ear, and that can disappear, whatever, with the steroids and so on. But it's a very good prognosis. The patient will recover within 3 months to complete recovery if he has a very good response here. And then we have the whole spectrum in between. If the patient has a complete paralysis, he cannot move, and you have 50% amplitude drop here compared to this side, then 50% is degenerated and 50% is just conduction block. So the patient will recover after a few months from the conduction block, and then it takes longer time to recover from the remaining 50%. So we think it's very good simply to compare CMAP amplitude of the stimulating here.
Yeah. Another question from Dr. Radwa. What about the parameters of neuro monitoring as good indication for scoliosis correction intraoperative? I don't know. Yeah.
I'm not expert in
ION.
monitoring. We have that in our laboratory. We
Yes.
have a couple of doctors that do that on daily basis. I do not do that on daily basis. I should not answer.
Thank you so much. Any question? Yeah. Okay. I'm really glad to see you, and I think it's not the last time. I think we have 2 more talks. I will prepare this with Professor Erik. Thank you so much, dear Professor. Good day.
Okay. Thank you. Thank you very much.
Bye. Okay.
Goodbye.
Bye.
Goodbye.
Bye. Okay. Yeah. Thank you so much for dear participants. I'm really excited to be at this webinars. I think we have 2 another webinars. I want hope to get more and more participants than today. I think in the WhatsApp link, I will get the link for the other talk with Professor Sanjeev. Very exciting tutor and very exciting topic. See you. Wassalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much. Lastly, I will get the handout of this talk in the group and the WhatsApp link. Thank you so much. Bye-bye.